in, and we'll start in just a minute or so. We get lots and lots of little beeping noises as everybody joins. Lovely to see lots of familiar names on the list. Okay. Still got lots and lots of people joining, but we will make a start, I think, because there's quite a bit to get through and we want to make sure that we have enough time for discussion. So just bear with us while the beeps continue to beep away for a bit. So morning, everybody. Thanks for joining us off the back of what I hope was a lovely, restful or exciting bank holiday weekend for you all. You can't tell from the slightly shadowy light in here, but I do have a very pink nose, which marks the start of the warmer weather in my household. My name's Kirsty Kitchen. For those of you who don't know me, I'm Head of Policy and Communications at the charity Birth Companions. This morning, we're sharing the key insights from our Birth Companions recent project for Tommy's and Sam's Maternity Consortium, exploring the impact of children's social care involvement on women's mental and physical health and well-being. There's lots of us here, more coming in the whole time. There were also loads of people that wanted to join us but couldn't for various reasons. So we are recording the event today and we will share it with all of you, along with those who have requested to have the recording sent to them afterwards. So you do feel free to send that on to colleagues and friends who weren't able to be here. Celeste, I'll pass over to you to introduce yourself. I will just do a few introductions so everyone knows who everyone is, and then we'll get cracking. Thank you.
Thanks. Hi, everyone. I'm Celeste. I'm the Maternity Consortium Coordinator and Engagement Lead at the Sam's and Tommy's Policy Unit.
Thanks, Celeste. And Angela.
I forgot to unmute myself. Good morning, everyone. I'm Angela Fraser-Wicks and I am a birth mom. My eldest two children were removed and adopted in 2004. I also have an 11-year-old daughter who has no local authority involvement. I'm chair of trustees at Family Rights Group and founding member of their parents panel, which is one of their expert panels made up of people with lived experience of the child welfare and family justice system. And I've been working alongside Birth Companions, bringing the lived experience element.
Thank you so much, Angela. Lovely. So without further ado, we'll crack on. I just wanted to introduce Birth Companions a little bit for those on the call who might not already know us or might know us in a sort of narrow sense. A lot of people know Birth Companions because of our focus on pregnant women and mothers of infants in the prison system, and that's where we started out back in 1996, focusing on improving the care provided to those women while also campaigning, as we still do, for an end to the imprisonment of pregnant women and mothers of babies. We are now the UK's leading voice on criminal justice in the community and in prisons, but also much more widely than that on issues around inequality and disadvantage as they apply to pregnancy and early motherhood. We have a focus on the systems that most often play into women's lives around disadvantage. So that's as well as the criminal justice system, that's the children's social care system, the immigration system, and obviously the wider maternity system as a universal service. We offer specialist antenatal education, practical and emotional support, lots of advocacy services, and a big part of my focus is working alongside frontline teams to improve policy and practice as it applies across the country and internationally to some extent as well. We have a lived experience team of over 50 women, many of whom have been involved in this piece of work that we're sharing today. And they are an amazing resource that some of you on this meeting might want to consider working with in the future. So do get in touch if there are pieces of work that you'd like to discuss. And in general, we have a very strong focus on understanding the social determinants of health, using them to inform better service provision and better policy. And increasingly we situate our work in the framework of reproductive justice, which really focuses on women's bodily autonomy, their choices to have or to not have children, and their ability to raise the children that they do have in safety and dignity. I will now just pass on to Celeste to talk a little bit about the Health and Wellbeing Alliance and the Maternity Consortium.
Thanks, Kirsty. Yes, I'm just going to give a very quick overview for anyone who's not familiar. So the VCSE Health and Wellbeing Alliance is a partnership between the voluntary sector, the Department of Health and Social Care, NHS England, and the UK Health Security Agency. And the alliance is made up of lots of different members who focus on a range of different health and social care needs. So it's not just focused on maternity, but as part of the alliance, Tommy's and Sans co-lead the Maternity Consortium, which includes National Maternity Voices, all of the organisations who make up the Pregnancy and Baby Charities Network, 5 times more, the Muslim Women's Network, and LGBT Mummies. And as I'm sure you can imagine, we focus on preconception up to the first year of a child's life. And as an alliance, we kind of work to 3 main aims around reducing health inequalities, facilitating partnership working between the voluntary and statutory sectors, and bringing service user voice to policy development and service delivery as well. And can I have the next slide, please? Thank you. And this project that we're going to hear about today came about from the Maternity Consortium's membership on the Health and Wellbeing Alliance. So in its current iteration, the Health and Wellbeing Alliance is a 3-year bit of funding. We're currently starting the 3rd year, and each year we deliver 3 projects which relate to the aims I just mentioned of the Health and Wellbeing Alliance. And in the 1st year, we did a project on the barriers to accessing maternity care for groups at risk of poorer outcomes. One of the key findings from this work was women and birthing people who had experience of children's social care assessment, telling us of, unfortunately, the negative impact that some of these experiences had on their antenatal and postnatal care. And in particular, we heard a lot of women who told us that they did not disclose mental health and wellbeing needs for fear that their child would be removed. So obviously this was a key finding from the project that we did want to take forward in our work. In the 2nd year of the Health Wellbeing Alliance, we did a project working with maternal mental health services and specialist perinatal mental health teams to support them to deliver more inclusive and accessible services. So we delivered a range of events, which some of you may have attended, really kind of sharing good practice across the voluntary sector and services to support the delivery of inclusive care. And we have recordings of those available if anyone's interested, so I can post the link in the chat once I've stopped speaking. And yeah, we got this opportunity towards the end of the 2nd year of the Health and Wellbeing Alliance to deliver a priority project, which was a kind of short January to March project, which focused on specific priorities that the Health and Wellbeing Alliance is working on. So this project in particular focused on maternal health, children's social care, and mental health and wellbeing needs. So those are kind of 3 priorities that the whole Health and Wellbeing Alliance membership is working on. So we got funded to deliver this priority project, which Birth Companions very kindly, as members of the Maternity Consortium, led for us. So yeah, I think I will hand back over to Kirsty to talk a bit more about the project and the report and the findings.
Lovely, thank you, Celeste. So here is the report that we're talking about today, my hastily printed copy, hot off the press. So the link to the report is either in the chat now or will be with you very soon. So that's available online as of this morning. The title of the report sort of explains it all really: Understanding Women's Lived Experience of Children's Social Care Proceedings During Their Pregnancy and in Early Motherhood. It's an insight report. It's been developed through a series of focus groups and one-to-one sessions with women with direct experience themselves of children's social care proceedings in pregnancy and the first 2 years of their child's life, reflecting the 1001 critical days, as well as some engagement with professionals who commission and or run services that those women might benefit from, or are designing services along those lines. We worked directly with the Ocean Service in East London to think about where learnings from this report might lead in terms of their own service design, which we'll talk about a little bit later. So the report is live. We don't have very long today, so we wanted to sort of share some of the key findings, really, the context for the report and some of the key themes that have emerged. But I would really encourage you to go away and read the full report. It's not hugely lengthy. It is an insight report. Is an opportunity to share some of the direct quotes and reflections that women shared with us during the project, and some of the kind of key context, really, that have relevance to tackling stigma and reducing inequalities and improving outcomes for women, specifically in these circumstances. But I would also add that, you know, if we can do that work collectively, we'll improve outcomes for women more widely, women who are carrying experience of trauma and abuse, women with experience of their care system themselves as children perhaps, and those who fear social care involvement, even if that fear is very unfounded. So I do urge you all to click on the link and download the report and share it widely after this meeting. So a bit of context. Tens of thousands of women have contact with the children's social care system during pregnancy and early motherhood each year in England. Some just have an initial assessment, some get early help from social workers, and certainly the vision set forth by government in response to the independent review of children's social care recently emphasises a sort of ambition to invest in that early help, that family help service more fully in coming years. Some do move into processes such as pre-proceedings or court proceedings, and unfortunately, for many different reasons, thousands of mothers have their baby removed from their care by the family courts every year. Between 2007-8 and 2016-17, so in less than a decade, the rate of newborn babies subject to care proceedings more than doubled, and that's research that was done thankfully by the University of Lancaster and the Nuffield Family Justice Observatory in their Born into Care series, which I would encourage everyone to look into if you're interested in the data behind this. There are really well-established links between maternal deprivation and care proceedings and observed high levels of pre-existing trauma, mental ill health, domestic abuse and substance use among women with children with social care involvement. Recent analysis, very concerningly, has shown a high and increasing rate of social care involvement among women who die during pregnancy, childbirth and the year after birth. The latest Embrace report that came out towards the tail end of last year showed that 20% of the women who died had social care involvement. That's risen from 17% in the previous report and 12% in the report before that. 11% of those who died by suicide and 59 of those who died through substance misuse had an infant removed into care or were subject to ongoing care proceedings. And for several of the women who died, the separation from their baby was observed to have led to an escalating pattern of mental ill health, substance misuse and domestic abuse. Despite the sort of weight of evidence, I suppose, of the complexity and the vulnerability and the risk associated with women in these situations, it is disappointing that they are largely invisible in many aspects of health and social care policy and guidance. even those that squarely focus on inequalities, including Maternity Transformation Programme, the NHS Long-Term Plan, Core 20+5, where there's an opportunity for them to be an inclusion group, but they're not specified as such. Perinatal mental health services also really struggle with this group, and we're aware that in a lot of cases, if a woman is receiving perinatal mental health support and then loses the care of their baby, they are taken off that perinatal mental health pathway and rerouted onto generic adult mental health services, which is an issue that we are very focused on helping NHS to address at the moment. They're also not noted in the equity and equality guidance for local maternity systems, and they're not listed in the NICE CG 110 guidance on complex needs, for instance. The needs specific to pregnancy and infancy were also not really emphasised in the independent review of children's social care, even though we advocated very strongly for them to be in there. So there's work to be done, which is where this report came from. The key themes from the report are split into two sections. The first section, which I'll talk briefly through, looked at women's personal experiences of how social care involvement had impacted their mental and physical health. It's worth being conscious of the fact that although we made this very much open to considering physical and mental health, overwhelmingly women in the engagement sessions that we ran and the one-to-one sessions wanted to focus on the mental health aspects, and that was definitely where their attentions lied. There were some references to physical health, but overwhelmingly it was mental health focused. So the first of the themes that emerged in that part of the work was the sheer impact of that social care involvement. It was absolutely one of the most significant things going on in women's lives. One woman said, "When I was told social services would be in touch, I lost myself. I felt like my world was crashing down. It triggered my previous experience and I panicked." I think Celeste mentioned that this work sort of developed out of previous work that had flagged concerns about the impact that fear of social services involvement has on women's ability to disclose the reality of their needs and to be honest and open with professionals about what's going on for them. And that was absolutely emphasised through this work. It was also really powerful to note, as we always come across when we speak to women in the course of Birth Companions work, that the fear is not directly related to the likelihood of children's social care involvement and or proceedings and or separation, just any indication that children's social care could be sort of brought into the mix. It becomes a debilitating fear for women very, very quickly. Something that we've seen in previous Birth Companions research as well is issues around knowing what is happening and what is going to happen. Women describe sort of fears of separation being exacerbated by the fact that they don't know what the process is, they don't know what conversations are being had, they don't know what the plans might be. So one woman said it's the anxiety that builds because you don't know what they're doing, you don't know what they're saying, you don't know what's coming next. There needs to be more communication during that process to better support women's mental health. So actually one of the women who took part in the work with us described being sent for a psychiatric assessment when her baby was newborn, but she had no idea that it was a psychiatric assessment that she was being sent for. She thought it was just a routine appointment, and then she left her baby with someone, a family member, to just look after for a couple of hours while she went to this appointment. She realised that if she'd answered some of the questions on that day differently, she might not have gone back to that baby. She might have been held in the unit that she had walked into without really understanding what was going on. So women were very, very clear in this piece of work that they want professionals to be honest and open with them. And I think sometimes there is a sense that women don't get information shared with them because almost out of a desire to be kind or to not add to women's sort of worries, but that actually builds the mistrust, and women do always tell us that they'd much rather know what's happening than not. It's not always possible, but I think clarity and openness of communication is really, really central to this. The women's past experiences of social care came into play a lot, whether that was their experience of care as a child themselves, or their experience of care proceedings for previous children. But they really wanted professionals to understand the impact that those past experiences have for them. The prevalence of domestic abuse among the women that we spoke to was really, really strong. And we know from Department for Education stats that domestic abuse concerns linked sort of are on a par with parental mental health concerns as the two leading causes for children's social care assessments to be done. So there is a really, really urgent need for all professionals working around women in pregnancy and early motherhood to be very aware of the interplay between domestic abuse and children's social care involvement. It was very powerful to hear women talk about how complex that is. They don't expect the health professionals to be experts in it, but they do need services to be available for them that can help navigate that complexity. One of the women described how she had the social worker on one side saying, you need to leave this relationship, and if you don't, your baby will be taken away from your care. But also then when she left, she lost all of because she had to leave the area, she lost all of the health and the mental health and the antenatal care that she had embedded already and had to start from scratch again. But no one had planned for that or helped her to sort of preempt that. And you know, and also women talking about the fact that they just weren't able to leave at that point, and the sort of judgment that professionals brought to that decision at that point was very, very heavy for some women. Unfortunately, all of the women that took part in this piece of work with us described having issues accessing the mental health support that they needed at the time that they needed it. That was very, very clear. Some women talked of asking for help but not being able to get it. Others talked about getting the sort of offered support that wasn't what they wanted, or going to their doctor and explaining that they were struggling in certain ways and being offered antidepressants, but actually not being offered the talking therapies and the support that they knew that they needed at that point. Others talked about finding really positive mental health support, but that it stopped very quickly or far too early, or when they didn't, when they needed it to be able to carry on. And lots of women talked about their struggles to source mental health support themselves outside of statutory routes. Those who had received what they considered to be appropriate mental health support, though, were very clear that it made a huge amount of difference. So one woman said, my mental health support has helped me stay present for my daughter, and all my daughter knows is stability. Despite all the storms, my mental health support means she doesn't know anything about that. And I think that's a really, really powerful reminder of how important it is to get it right, because it can be transformational for women. Same goes actually for midwifery support, where women had really good midwifery support from specialist midwives who understood the complexities of children's social care involvement. That was really, really powerful. Women also talked about other health professionals, you know, really great health visitors, for instance, but then they shared other versions of experiences where being honest with a GP about their situation sort of fell on deaf ears, really, and GPs, for instance, not understanding the impact of trauma or the fear of social services involvement. So it's a very mixed bag, and there is more detail in the report on that. In the second section, we were really keen to look at how these women's experiences might be fed into changes to services or new services or slightly tweaked service designs that would be better able to respond to women with children's social care involvement. And we had professionals from midwifery, maternal and perinatal mental health provision, maternity commissioning, like I said, in East London particularly, involved in those conversations. And the themes that emerged from that, again, were very, very clear. Overwhelmingly, there was a recognised need for specialist services rather than services that sort of try to tag on provision for women with these particularly complex needs and experiences. It was put incredibly powerfully by one woman who's featured in the report. She said, "There's grief therapy. My children aren't dead, but they are dead in my life. They are dead in my world. They've been with the foster family for 5 years and they're biologically mine, but they're not mine. There isn't anything available to deal with feelings like that. There does need to be something specialist to that set of experiences. Also, it needs to be sustained, because women talked of finding a service and it ending, or finding a service and then not meeting the criteria past a certain point. And that's another loss. Actually, one of the women involved in the research described her upcoming sort of rerouting from a service that she was on and had been on for a while, as she was expecting to experience it as another loss when that service came to an end. And obviously no service can work with a woman for an indeterminate period, but there does need to be a sustained pathway and a supported transition between services. It was really interesting that women and professionals all recognised the difficulty of taking the first step to accessing a new service as well. It's not enough to just offer the service, but you need to be very aware, women felt, of how daunting it can be to step into a new setting, build a relationship with a new professional, and to make sure that that engagement feels positive. One woman said, "I almost didn't go to the group session I was referred into," and she was referred by a safeguarding midwife. "But I almost didn't go. I couldn't see what it would do for me. But I also thought, I don't want to be seen to not be doing something that I'd been referred into by safeguarding." So even though it was an optional service run by a voluntary provider, she was still worried about what it would mean if she didn't go. So she ended up going, and she said, "I thought it might be compulsory, and there'd be consequences if I didn't go. So I went, and then I realised how good it would be for me." So we need to be supporting women to understand what a service is going to give them, why it's worth them engaging, but also to make that whole transition feel safe and positive for them. A lot of the women that we spoke to had received birth companion services, so it's not surprising that they spoke very highly of the voluntary sector as a provider in this mix. Not just us, but other voluntary sector organisations as well. And there was a real sense from them and professionals around them that voluntary sector organisations can find it much easier to engage with women and to build that trust, and they can act as a bridge with statutory services as well. There was also a lot of appetite for peer support, peer-led services, and group sessions where women can support each other. Absolutely, women felt that group sessions sort of subverted a lot of the power structures that they had been subject to in their lives, that it was women looking after women, that it was women who understood each other, and that group sessions allowed, if they were well run, allowed for a lot of different ways for women to heal, through talking, through listening, through taking a back seat, through doing arts and crafts, through sharing skills. You know, there were so many wonderful experiences talked about in terms of group sessions. But then that brings us on to the final point, which is the need for a range of flexible services, because women were very clear that there were points in their journey where a group session would not have been the right thing for them, that they needed one-to-one provision, intensive provision at times, and then more flexible, more light touch provision, and that needed to work it both ways, so that if you were in a group service, that you needed to have the option to go back into one-to-one services if you needed it, that things might come up in groups that are very triggering, that there might be something else that happens in a woman's life, and it isn't enough to have a one-size-fits-all kind of approach. It's probably a good point for me to invite Angela to share her thoughts and experiences on these kind of themes, really.
Thanks, Kirsty. It's not going to come as a surprise that I agree with all of the findings, and actually listening to you speak there, you could have just been telling my story. You could have been talking about what it felt like for me going through the process, and which means I can't stress enough the importance of tailored support for pregnant women where children's services are involved. Because I mean, pregnancy is a terrifying time for any new mum. I think we can all agree on that. But when you add children's services in, that fear, it becomes terror, because you have so many different people telling you what to do, but very few, if any, are actually helping you do any of it. And often healthcare professionals are giving mum different advice to children's social care, and mum just doesn't know who to listen to. And without any relationship with either, that's really very difficult. To put it into context, in my case with my second son, I had local authority involved, and I was a high-risk pregnancy, needed a great deal of additional medical support as I'd had life-threatening complications following the birth of my eldest child. But nobody listened, no matter how many times I asked for help, no matter how many times I told them how scared I was, because I was simply seen as a risk because I had local authority involvement. In reality, I was an incredibly vulnerable pregnant woman. And sadly, as a result of that, I went on to suffer horrific complications during and after birth, where I almost died because nobody'd taken me seriously. And even then, additional support still wasn't provided, and I deteriorated rapidly, both physically and mentally. And eventually, that was used as a reason to say I couldn't cope and my baby was removed. So, because often the system is so focused on risk that it doesn't seem to understand that actually by providing comprehensive tailored support for mum, this in turn safeguards the baby. Because a mum, like you said, Kirsty, who feels able to talk to the professionals involved with her about her worries, concerns, without fear that this is going to lead directly to the removal of her baby, it's the only way to ensure that the woman receives the correct level of care for her needs. Because we're often so critical as a system of a woman's failure to engage without acknowledging that we haven't done anything to help them build trust so that they are actually able to engage. None of us wants to just sit down and have a conversation with someone we've never met about some of our most traumatizing experiences. It's part of human nature. And a big part of this, as you mentioned, Kirsty, is a woman knowing what's going to happen, when it's going to happen, who's going to be involved, so that we actually feel like we have a bit of control, and then we're not just part of the process that's simply being done to us, because that in turn just adds to the trauma that we're feeling and the fear that we're feeling that things are being done without us. And when we talk about trauma as well, the term mental health is so often banded around and written on files without mum ever having had a proper assessment or a proper diagnosis. I know the prevalence of the personality disorders, here borderline personality disorder was put down on a file. And because if a woman's mental health is raised as a concern, surely it's only right that should automatically trigger a right to tailored mental health support. It's not good enough for us to just say our mum has mental health problems and do nothing about it, because often what is needed, and what was needed in my case, is trauma support. But this is very rarely available. And if it is, the waiting lists are far too long, and then sadly don't fit in with the timescales that have been set by children's services. So the woman's then penalised for not having addressed mental health problems that she wasn't able to address. And that's just simply unfair, in whichever way we look at it. And then when we come to dealing, and that's if we're dealing with mum who hasn't had a previous child removed. When we step into the arena of dealing with a woman who's had a previous child removed, the need for support escalates massively, because quite rightly, when we deal with the woman whose baby died after birth, we wrap around support for that woman. We treat everything we do is done in a compassionate manner because we understand that loss and that grief. But you know, as the woman you were talking about, Kirsty, mentioned, using a child to the care system carries the exact same level of grief and loss. So you need a similar level of support, because no one ever puts them back into that position, having lost a child previously, without being acutely aware of the potential consequences of this not working in their favour and actually being able to lose another child. And I think we need to be seeing that as a strength, not a weakness, and use that as a reason to step in and support mum. Because at all points throughout the journey, the professionals involved should be seeing a vulnerable pregnant woman with additional support needs. Midwifery should walk alongside the woman, because after all, that the definition of the word midwife is to walk alongside the woman. And the woman should be able to feel seen, heard and supported by her midwife, and know that they will advocate for her and her baby's needs. Feeling like maternity and social care are plotting together and you don't know what's going on is truly terrifying and shouldn't be a woman's experience of maternity services. And we also touched on there about domestic abuse. And, you know, the need for domestic abuse awareness is crucial, because a midwife appointment might genuinely be the only opportunity that that woman gets to talk privately. In my case, I was a domestic abuse victim and my partner shadowed me to every single appointment with the local authority. But the only place he didn't shadow me was my maternity appointments, because he didn't like hospital. So that should have been my opportunity to be able to speak out, to share my concerns, to feel safe. But because I knew that nobody in that hospital setting was listening to me, that all they were seeing was risk, I was terrified, because all I knew was I was going to be adding another risk. They weren't actually going to see that as an opportunity to help me. So at that point, I didn't trust anyone. And having gone through three pregnancies, I didn't actually have a trusted relationship throughout any of those pregnancies. Every pregnancy, despite the fact my daughter, we had a pre-birth assessment and we were NFA'd, that didn't stop me being terrified. That didn't convince me that no one was going to come and take her away. I spent the first year of my daughter's life on quite serious antidepressant medication because I genuinely didn't believe someone wasn't going to come and take my baby away, because everybody in my previous situations had said, don't worry, there's nothing to worry about, we haven't got any concerns, when actually they did. They just weren't telling me. So as you said, that lack of honesty in those pregnancies meant I didn't trust anybody in my third pregnancy. And actually, fortunately for me, very shortly before the birth of my daughter, I was diagnosed with complex post-traumatic stress as a result of everything that had happened, not just with the births, but with the removal of my children. But sadly, it took another 11 years to access trauma therapy, which just really shows the gap there that's needed for people like me who have been in that situation and actually need that support. It was only because I was lucky enough to be supported by a family rights group, my fellow panel members who provided peer support, and that I have a very strong family and friends network around me, that this time I was actually able to get through it. But without that, I would have been in exactly the same situation as I had before. So really, it's just to try and really emphasize that all women deserve to be properly supported pre and postnatally, regardless of their involvement with children's services. But we really need to start seeing previous local authority involvement or current local authority involvement as a red flag for support needs and not just a red flag for risk. And I'll leave it there.
Thank you so much, Angela. Yeah, that was incredibly powerful and raised some very very important points, I think, in terms of considering the conclusions from this report and where it leads us, because you know this is a piece of work that was always intended to act as a stepping stone into further work, really. So thank you for that. I think, as you've just so perfectly said, what this work and other work that we've all done in this space shows is that there is a need for specialists and sustained provision. and that it is particularly important in terms of addressing mental health needs, and the fear and the reality of separation from a baby, but also the physical aspects of that too. And lots of studies have shown that the current provision isn't specialist and it isn't sustained. There's a huge amount of great work that goes on where it is individual healthcare professionals, be they maternity, mental health, whatever, and social workers who are operating in ways that are in spite of the systems rather than embedded within the systems. They are going beyond their roles, they are going beyond the expectations, they're going beyond their training and their expertise very often, because they're driven by a compassion and a care for the women that they encounter. But what we now need to do is take all of that knowledge and care that it does exist and embed it in the systems, so that it's there for everybody that needs it when they need it. So that's why at Birth Companions, we and others in this space, are really focused on what we at Birth Companions call a national health and social care pathway. And Angela and one of the women that I quoted earlier have both talked about the grief of separation, and the precedent that's been set by the National Bereavement Care Pathway in maternity services is really positive. It's now time for us to have something akin to that for women with children's social care involvement that runs across health and social care. There's also work to be done in thinking about how maternal mental health services, which are the only service so far that has got a specific expectation within it, I suppose, for working with women in these circumstances, to sort of make sure that they are able to do that work. I know that the evaluations done so far have shown that maternal mental health services around the country are really struggling to put provision for this group into the mix in a way that is sort of to the same degree as the provision that they're putting in place for women experiencing other forms of birth trauma or birth loss. And there are really good efforts going on there, but there is probably going to need to be both much more emphasis and more resources put towards those services if they are going to be able to include a specialist provision for these women, I believe. Birth Companions is also going to be publishing a new birth charter. Some of you might be familiar with our birth charter for women in prison that we published a long time ago now, 2016. But we are publishing a new birth charter for women with children's social care involvement in the summer, and we will share information about that as soon as we've got the date confirmed. But that will set out a sort of set of principles of care for the treatment of these women, overarching principles really that can be applied across health and social care, and many of the findings from this report will be reflected in those. I've just seen questions pop up about how to access the report. We'll repost the link to the report, and also we'll share the recording from the session afterwards today, so that people can catch up. So that's probably enough from me in terms of what the report says. We really wanted to just open up some time for discussion. We've got 15 minutes left, so we'll try and capture some of the questions that have been posed in the Q&A, and do keep posting them. Celeste, I haven't had the Q&A open, so hopefully you've been able to spot some points for us to discuss.
Yes, we have a couple of questions. So as people are thinking them, I thought as well it might be helpful to just share very quickly how we're going to take this forward through the Maternity Consortium and the VCSE Health and Wellbeing Alliance. So as I mentioned right at the beginning, we've done a number of projects which kind of relate to this priority project that we've been working on. And in this year's kind of Health and Wellbeing Alliance work, we are delivering a project exploring the link between suicide, domestic abuse, substance use and trauma. So we'll be working further with women and birthing people with lived experience and with complex needs, who to kind of understand their experiences and how they think services and support can be improved. And then again, we'll be kind of sharing the findings in a similar way with a report and an event. And we're hoping to kind of follow this on if the funding through the Health and Wellbeing Alliance continues to develop some kind of tools for professionals in services that might be useful to them. Again, working with women and birthing people with lived experience. So the first question that's come up is around who participated in this work, so around kind of how many women were involved and what the ethnic representation was.
Yeah, that's a good question. I am trying to remember off the top of my head, and I don't have the number in front of me. I think it was around 10 women in total with lived experience, maybe 11, fed into the piece of work. It was deliberately small. It was mixed in terms of ethnicity, but not in a representative way, not representative of the population as a whole, and not necessarily, deliberately, unfortunately, not necessarily representative of the women who do enter the family justice system each year through children's social care. That's largely as a result of this being quite a focused piece of work with a short time turnaround, but also the very, very sort of difficult nature of these conversations and the need for that to be a very self-selecting group of women who feel able to share those sorts of experiences. So I know that there are ambitions to do much more representative pieces of work, and we have done specific pieces of work recently. I'll try and find the link while we're talking about something else to post it in, unless Catherine can, but we did a piece of work for the Nuffield Family Justice Observatory, for instance, thinking about the links between ethnicity and experience of the family justice system, specifically with Black and brown women taking part. And I will try and share that. Certainly not what we would call a representative sample.
Thank you. A similar question around who participated. Was this women's experiences nationwide or in a specific area?
It's predominantly women in London and the southeast, because of that's where our service footprint is strongest. So yeah, not a scientific study, very much a chance to gather some insights to inform bigger pieces of work. Angela?
Actually, it was just to add into that my experiences were in northern area of the country for my first two. I'm currently in Norfolk for my third, and despite the fact that this may not have been a national piece of research, I can tell you that there's no difference between what these women have said and what my experiences have been in two very different areas of the country, if that's any help.
I think that's a very good point. That being said, there are huge differences in the rates of care proceedings around the country in infancy and at birth. So while I would reiterate, I think the themes are very common across the country in terms of women's experiences, but the rates of care proceedings are very, very varied. And there are interesting theories about the reasons for that, which we probably don't really have any time to touch on today.
Thank you. Next question, is work needed around pre-birth assessment processes?
Angela, you'll have something to say on this, but I would say yes, absolutely. absolutely, and something that we advocate for as part of the shared health and social care pathways, an emphasis on pre-birth assessment and pre-birth support. And it is well known and well evidenced that there has been a real shift to crisis level intervention after birth, where actually a better process in the pre-birth phase might have prevented needs escalating to the point at which a decision needs to be taken in a very kind of high stress period immediately after birth. But Angela, I'm sure you want to comment on that too.
Yeah, in a word, yes, we do need to see a lot more work done on the pre-birth stage, and really understanding just how vital that time is, and how much it's surprising how much work can actually be done in that stage. I think a lot of the time we think, oh well, we've only got another 10 weeks, mum's not going to be able to make the changes necessary, when actually if we put that tailored support in, mum's more than capable of making those changes. She wants to make those changes, she just needs some help. But I think the work that we did as part of the Born into Care study at Lancaster, and the guidance that we produced at the end of that, was really looking in depth at that pre-birth time and what it feels like for women in that assessment, and how, I mean, just the fact that we call it a pre-birth assessment as opposed to pre-birth support or pre-birth, it really sort of speaks volumes, I think, for how that time is viewed, and how that time can sometimes be used, when actually it should really be used as a time to just provide that really intense tailored support to mum. And I know that Family Rights Group and Lancaster are doing some work at looking about the use of family group conferencing in that pre-birth space, and how actually, if we can, rather than just relying on professionals to sort of fill the support needs, actually if we could look at really strengthening the existing support networks that mum already has, and how we can utilize that to give mum the best possible chances, then that needs to be done. But yeah, no, as I say, I think it is a space that I do think we need to see some. We can't just keep worrying about the things after birth, we have to really step in. And it has been quite good to see that a lot of local areas now are allowing referrals to come in at earlier stages of pregnancy, because I know that has in the past caused huge. With my daughter, I referred myself knowing they'd want to do a pre-birth assessment, and was literally told, we will not see you until you're 6 months pregnant. So I then had to spend 6 months being pregnant, not knowing whether they were going to have any concerns, not knowing what changes they might want me to make, and you know, that just wasn't acceptable. So I think that, as well as looking at what we do during pre-assessment, I think we need to be looking at when that pre-assessment starts, and it really needs to be starting as soon as possible, so that we give mum and baby the best possible chance of staying together at the end.
Yeah, I'd support that, actually, because I know that through the work of the Born into Care team, that there has been a sort of a real step change in some local authorities about the whole approach to the pre-birth period. I think the other thing to emphasise is that lots of local authorities used to have pre-birth and infant specialist teams, and those got sort of wiped away gradually as a result of funding cuts and restructuring. And I know that there are lots of efforts to bring those back, and some local authorities have already done that. And I think what that also does is, as well as allowing you to embed processes like earlier pre-birth referrals, it means that you can also build up expertise and relationships across professionals in local areas, so that the pre-birth and infant specialist team, social workers, have very good working relationships with, for instance, specialist midwives in the hospital, and they can sort of share and build that expertise over a period of time, rather than endlessly working with new processes and new people. So that's a really positive development.
Thank you. B had their hand up. I'm not sure, it's gone down now, so I'm not sure if you still wanted to ask your question, or if you want to post it in the chat. It has gone back up, so I don't know if Catherine can unmute.
This is the joy of Teams webinars with large
You
numbers
should be
of
able
people.
to ask your question now. I've unmuted you.
Hey, it's not so much a question. It's just to say that my children were removed from me 10 years ago. I had a daughter 2 years ago, and everything everyone has said so far is basically the repeat of my story. And this is the first time that I have not felt alone. And I felt, I don't know. So I just wanted to say thank you, really, because I don't feel alone anymore. Even though I have amazing support from a midwife and Jenny, who's here, who invited me. Yeah, I didn't know about the support groups that any of you have mentioned, and we were discharged from social services about 18 months ago, I believe, and this is the first time I've heard any of it. I was diagnosed with PTSD due to safeguarding literally a couple of weeks ago. I'm due next month, and it is absolutely terrifying. Absolutely terrifying.
Oh,
So yeah.
Thank you for speaking up, Bea, and I'm so pleased that you feel less alone. And if it's any consolation, I was absolutely terrified of starting trauma therapy, and it's turned out to be one of the best things that's ever happened to me, and it's helped me with so much. And I'm so pleased that you're finally getting some help. But more than anything, I'm so pleased that you were a success story, and we need to stick together. But thank you so much for letting us know, and you are definitely not alone. And I find it quite sad saying that you're not alone, because there are a huge number of mums like us who've been through it and have come out the other side battered and bruised. And I wish you all the best with the trauma therapy, and really it has absolutely changed my life, so I really hope that it does the same for you.
Thank you.
Yeah, Bea, do get in touch with us. My email address on the slide, and you know where we are now. So if there is anything that we can do, we absolutely will. So, but please, yeah, don't feel
be in
that
touch.
you're alone. Yeah, thank you.
Thank you.
Thank you so much for sharing that. That takes a huge amount of bravery to share, to speak up and share. So thank you. What a note to end on, Celeste.
Yeah, I was going to say there are still some more questions in the chat, but I think we've sadly run out of time.
Yeah, and if there's a quick one, we could probably do it, but it might be tricky to squeeze in. And I'm very conscious that everyone's come back to work after a bank holiday weekend, and I'm very, very appreciative to see so many people joining us online to just listen and think about these kinds of issues. That in and of itself is just incredibly powerful, because as Bea and Angela and many of the women said in the course of putting together this work, they are very often the invisible women. They are the invisible mothers, and we don't want that to continue. And it's a real step forward to be hosting this morning. So thank you just for coming along and taking time out of your day to focus on these women and their experiences. The report is available online. We will share this recording as well. Bea, please do message me if you would like us to edit out your comments. That is absolutely fine. I'm conscious that we'll need to check that before we send out the recording. But do alert your colleagues to the report and share it widely, and we can keep this conversation going. Thank you, everybody.
Sorry, I'm more than happy for that to stay in if it helps other people.
Thank you so much, Bea.
Thank you, Bea.
Okay, goodbye, everybody. Thank you so much. I hope you have some time to rest and just decompress maybe a little bit from this morning before going into the rest of your day.
Thank you, everyone.
Thank you.
Thanks, everyone.